Okay, so my name is Russ Derry. I'm the Director of Education at Epilepsy Foundation of Michigan, and the topic today of today's Learn and Share conference call is epilepsy in adolescents, and we're very happy to have with us on short notice Dr. Jules Constantinou, who's a pediatric epileptologist at Henry Ford Health System. So thank you so much for joining us. I know it was kind of last minute, so we really appreciate that. So can you give us a brief overview of your clinical and research interests and also your experience with this topic?
Okay, Russ. So yeah, I'm a pediatric neurologist, and I have a special interest in epilepsy. So I'm an epileptologist. So I trained in pediatric neurology in Australia, and I completed sort of pediatric neurology fellowship at the Royal Alexandra Hospital for Children in Sydney. I did an epilepsy fellowship at Boston Children's Hospital, and I was there for 2 years. I returned to West Australia, where I set up epilepsy monitoring and epilepsy surgery for the children of West Australia. It was the first time we had surgery facilities available. I'm more of a clinician in the sense that I don't do bench research and stuff like that, but I think my interests are in epilepsy, in accurate classification of seizures, in good medical management, and I think particularly in light of the topic that we're discussing today, I think, epilepsy oftentimes extends to more than just seizures. I think there's a lot of times, especially for teenagers and adolescents, and it's such a critical time and such a turbulent time for the teenagers, that we're dealing not only with seizures and issues of chronic illness, and but also, how do we foster independence? How do we foster control? How do we foster self-management? And how do we encourage our teenagers and adolescents to sort of take control and move on independently as they transition from adolescence to adulthood?
Right, exactly. And that's exactly what we'll be talking about today. So let's start by talking about epilepsy and its relationship to adolescence. So epilepsy often appears for the first time in adolescence, and then in other cases, some children outgrow their epilepsy as teenagers. So can you give an overview of the most common types of epilepsy that either start in adolescence or remit in adolescence or early adulthood?
Yes, that's a good question. I mean, certainly there are benign epilepsies of childhood, and probably the most common of those is benign Rolandic epilepsy or benign partial epilepsy of childhood. The children are normal and they'll have occasional sleep-related seizures. And with benign Rolandic epilepsy, we almost always expect you to outgrow the seizures. Childhood absence epilepsy or pédimale epilepsy is also a very similar epilepsy, a different type of seizure, of course, the absence of the pédimales. But that type of seizure disorder, we expect you to outgrow. Epilepsies which often present in adolescence, there's probably the commonest is juvenile myoclonic epilepsy, and so these are teenagers, normal teenagers. There may be a family history of epilepsy, but usually at 15, 16 years of age, we'll have a grand mal seizure, sometimes brought on by sleep deprivation, staying up all night. We always have to ask about myoclonic seizures, which is sudden shock-like movements. So JME or juvenile myoclonic epilepsy, it's about 6% of the epilepsy, but probably one of the commonest epilepsies beginning in adolescence. Juvenile absence, it's an absence epilepsy, which is similar to childhood absence, but it presents in, 11-year-olds, 12-year-olds, 13-year-olds, and in that sort of, you may have grand mals as well. And so in these adolescent epilepsies, there's often a lesser tendency to outgrow the epilepsy. So if we diagnose JME or juvenile myoclonic epilepsy, we'll often say, you're probably likely to suffer from seizures, or stay on medication the rest of your life. So I always worry a little when I see teenagers who develop new onset seizures, because I think it's always hard to say the likelihood, but many times seizures which develop in the teenage years might imply, long-lasting predisposition to seizures.
Okay. So in addition to epilepsy starting or going away at adolescence, sometimes you see changes in seizure patterns, seizure types, or seizure frequency during puberty or adolescence. It's obviously hard to predict what these changes will be, but can you explain why we see them? Is it hormones? Is it changes in the brain, or something else?
So that again is a difficult question, and not one that I think we fully understand. And I think hormones many times is the easy explanation. I think it has more to do with brain processes. Adolescence is a time of brain growth. I mean, your brain keeps developing up until you're 26 or 27. When you're an adolescent, your frontal lobes are enlarging. You're beginning to develop abstract reasoning skills and problem-solving skills, and sometimes it's a bit of a struggle getting there. So I think it's more to do with the intricacies of brain development and how we govern, how neuronal excitability is influenced by these maturational processes. If we look at temporal lobe epilepsy, for example, Arnstead, he was one of the big fathers of childhood epilepsy. In the early 60s, he did a monograph on temporal lobe epilepsy in childhood, and probably one of the first to emphasize or talk about options for epilepsy surgery. But if you look at Arnstead's original monograph, what he talks about is a silent period. So, and it'd be interesting to know if anyone that's listening whether they've gone through this. But sometimes, we'll see children that have epilepsy, and they're 5 or 6 or 7. And then we see a silent period, and the seizures seem to dissipate or to go away, and you think maybe you're outgrowing the epilepsy, and then boom, your seizures come back in adolescence. So this phenomenon of a silent period of between the transition of mid-childhood to adolescence, of there being a hiatus, a temporary remission of the seizures, is well recognized. It's very hard for me as a neurologist sometimes to predict, and many families want to know what's going to happen if my child has seizures, if my teenager has seizures. And one of the studies that I like to remember and think about is Campfield's study. So Campfield is a very senior epileptologist, very well known in the American Epilepsy Society, and a couple of years ago he presented an abstract at the society meeting. What he did was he went back and he looked at all the children he'd ever diagnosed with epilepsy, and the question that he asked was, he said, some families, I asked them, I told them their child was going to outgrow their seizures. Other families, I said, your seizures are likely to continue into adulthood. And he said, well, how often was I right? And, so how often do you think he was right, Ross? I don't know if you know his study or not, but he found out that 50% of the time he was correct. So sometimes you might as well spin a coin. So, and I think that's part of the challenge of epilepsy, is that a lot of times it's unpredictable. And I think it's hard for families, and it's hard for adolescents as well.
Right. So are there any common factors related to adolescence that influence your treatment decisions for teens with epilepsy?
I mean, when we think about treatment options for epilepsy, I think the main consideration is seizure type. What is the type of seizure? Because you want to tailor the medication that you're going to use, your seizure medication, for the type of seizure. So, if it's a juvenile myoclonic epilepsy, you don't want to be using medications like trileptal or dilantin, because that might make seizures worse. We have you want to, if it's an absence seizure disorder, you are going to use an absence medication. So you want to tailor the seizure medication to the type of seizure. If you think that this is going to be a long-lasting epilepsy, and again I come to JME, so where we say that, or juvenile myoclonic epilepsy, where we say the risk for seizures is going to be lifelong, we're probably not going to want to use a medication like Depakote, especially in a young woman, not only because of side effects, but, there's issues with metabolic syndrome, putting on weight, maybe polycystic ovary syndrome. There's issues of teratogenicity, which maybe we'll talk about later. I mean, most women with epilepsy have healthy babies, but some medications will increase the risk of birth defect. And Depakote is a medication that we know it can be associated, especially in higher dose, can be associated with birth defect in as many as 20% of children. So we want to think about long-term side effects if it's a medication that we're going to be using for a long time. I like to look also, seizures. The other issues that we look at in an adolescence are learning issues, attention issues. If I get the feel of an ADHD, I might want to use a medication which is more psychotropic. Some medications may make attention issues worse. We want to think about mood disturbance, which is common in teenagers. So if a teenager had either anger issues or depression issues, I might not want to use a medication like Keppra. So there's a lot of issues. I mean, if there's issues of compliance and adherence, you might want to use a medication which you can use once a day instead of twice a day.
Right. Okay. Makes sense. So if a teen is a good candidate for epilepsy surgery, I'm guessing you often encounter resistance from the teen just because they're old enough to understand the possible implications of surgery. So obviously each case is different, but what are some of the general arguments for having surgery in adolescence as opposed to waiting?
Right. So epilepsy surgery is always a tough decision for families, and it's never an easy decision, and many times it does take years to sort of get used to the idea. And, if you look at the average age of temporal lobectomy, and temporal lobectomy is our most effective epilepsy surgery. So, whenever I talk to people about epilepsy and what to expect, 60% of the time epilepsy is what we call smooth sailing. I can stop the seizures with the first or the second medication that we try. A lot of children do outgrow epilepsy, and if we can put you on medication for a couple of years and you're seizure-free, we can stop your medication. So that's what we call smooth sailing epilepsy. 20% of the time, it's a rough ride. I have to try one medication, combinations. Eventually, I can get there and I can get you seizure-free. But 20%, 30% of individuals have what we call a drug-resistant epilepsy. Mm-hmm. And if you're one of those 20, 30% that has drug-resistant epilepsy which doesn't respond to medication, then epilepsy surgery may be an option for you. And especially if you have temporal lobe seizures where, there's a 70, 80% chance that you might become seizure-free. So if we look at, people that have temporal lobectomy, the average age is about 35 to 36. And if you ask people how long they've had seizures, 2/3 will tell you that they've had seizures at least since they were teenagers or since childhood. So we've had seizures, many of us, when we have surgery, we've had seizures for at least 20 years. And so the question becomes, you become seizure-free, but does that really change your quality of life? And, unfortunately, when we look at people that have successful epilepsy surgery later in life, the improvement in seizures doesn't always translate into better quality of life. So, if you've gotten used to not driving, if you've gotten, employment, epilepsy many times impacts on employment opportunities. It impacts on how you view yourself, so anxiety and depression. So what we find with adults that have waited is that sometimes things don't change so much just because you had a successful operation. So we are waiting too long to do surgery. And so, what are the barriers? I think the barrier oftentimes is there are many reasons that we think this might happen. Sometimes it's maybe ignorance, or sometimes people with epilepsy will be told, well, you just have tough epilepsy, and if you have a seizure or two a year, that's the best that we can expect for you. Sometimes maybe it's fear. I think it's brain surgery, it's not toenail surgery. And it's a big decision. And so I think it does oftentimes, you need to think about it, you need to think about the benefits, you need to think about the risks. There's many different types of epilepsy surgery. If you have a temporal lobe epilepsy with hippocampal sclerosis and a well-defined lesion, then surgery is very successful. On the other hand, if it's what we call an extratemporal epilepsy, which is an epilepsy which begins outside the temporal lobe, where the MRI there's no lesion, surgery is less successful, and success rates vary. Sometimes we'll say 30%, sometimes we'll say 50% seizure freedom. In extratemporal epilepsy, we may need to do what we call a phase 2 evaluation. So usually the build up to surgeries, we do phase 1, you come in, we put electrodes on your scalp, we record your typical seizures, we try to figure out what area the seizures are starting from. Is it an area that's amenable to surgery without causing side effects? But sometimes at phase 1, your scalp's pretty thick, so your scalp electrodes dilute the signals. So what can we do, to help define the seizure focus more accurately? So sometimes we'll do a phase 2. Every center does them slightly differently, but you come in, the surgeon lifts a bone flap, we put electrodes on your brain. Extratemporal foci sometimes spread quickly, sometimes it's hard to pinpoint. Sometimes we do, though. And then everybody looks at things a little bit differently. So some people will say, Doc, we know that once you've been on 2 medications which are appropriate for seizure type. The chances of becoming seizure-free with a 3rd or a 4th medication are only the order of 10%, 20%. So if we look even at an extratemporal epilepsy, the outcome, a 30% chance of seizure freedom, is better than 10 or 20%. So everybody looks at things a little bit differently. Some people will say, well, you know what, doc, that's my best chance of becoming seizure-free is doing the phase 2. This is in the, if it's an extratemporal epilepsy, let me do it. Other people will say, you know what, doc, I'm not going to go, really, it's only 30%. I'd rather just live with my seizures. So there's a lot of factors which go into whether or not to proceed to surgery. And then one thing that, there are risks to epilepsy surgery, which people always think about. But, the risks of surgery are relatively small. If you look at, there is major surgery, and any major surgery has maybe a 1% or 2% risk of something serious, of something bad happening, whether it's death sometimes, or meningitis, or bleeding inside the brain. But if you look at the risks of surgery, which are very low in a good center which does lots of surgeries, over time the risk of surgery approximates that of uncontrolled epilepsy. So, this is always a difficult topic to think about and to talk about, but very rarely, what I'm talking about is the sudden unexpected death in epilepsy, or SUDEP. And the risks, if you look, if you have 1,000 people in your clinic and they all have tough epilepsy, and we know that people that are most likely to suffer SUDEP have grand mal seizures in sleep. But the risk of SUDEP in a tough epilepsy is about 6 per 1,000 per year. So it's similar to the risk of cot death or near-miss SIDS. But over time, the risks of uncontrolled epilepsy approximate the risks of surgery. So, people always worry about risk, but I think what you do is put them in the context of what are the risks of epilepsy.
Right. Now, does brain plasticity play a role in the decision to do it earlier versus later, because the brain has more plasticity when you're younger and you're more likely to compensate?
Again, that's a good question. I'm not sure that brain plasticity is the idea that if the earlier you operate, if you remove an area of the brain which is important for function, then there is, if you remove the area of the brain, there's the idea that other areas of the brain will be able to take over other functions. And, that's a good idea in theory. People have hypothesized that the earlier you do temporal lobe epilepsy surgery, you're more likely to see, less memory deficits after surgery. You might see better schooling, better academic performance. But if you look at the childhood pediatric surgical literature, it's actually been very, very hard to prove. Now, maybe that's because, each center has relatively small numbers. Maybe it relates to how long we wait for surgery. I think plasticity is always a consideration. Certainly when I'm working in the epilepsy unit and I see people, and sometimes in our unit we'll see adults, and, a not uncommon thread is that, my memory's getting worse and worse, doctor, the more seizures that I have, my memory's not as good as it was. So that is a consideration, but it's, and that really is the push to early surgeries, is because hopefully we can optimize social and cognitive and vocational outcomes, but it's been difficult to prove.
Right. Okay. So another treatment that is available but probably not used very often is the ketogenic diet. Because teens have already been exposed to a normal diet, the use of the ketogenic diet is obviously challenging because they know what they're missing out on. Have you ever worked with a teen patient who successfully used the ketogenic diet or one of its variants? And if so, what were the keys to success?
Right. I mean, I don't have any patients of mine at the moment on a ketogenic diet in adolescence. I think it's just very, very difficult in a teenage. I don't know if you, and you know, if we do recommend diet, it's going to be a modified Atkins diet. Okay. You know, which is high protein, high fat, minimal carbohydrate, and there's some enthusiasts for that, and who say that it's as good as the ketogenic diet. But it's not really one of the things that I emphasize a lot. Okay. I think it's so difficult, and I think it's really hard. I don't know if your experience is any different, Russ.
I mean, it all depends on who's talking about it. I mean, we did a conference call on the ketogenic diet with a ketogenic dietitian who she, you know, felt strongly that, you know, despite the difficulty in tolerating it and sticking with it, that it's still very effective at any age, and the biggest challenge is just being
I mean, yeah, I think it's just tough, and you know, there's so many medications these days that, you know, and any one of them, you might say, has an outcome similar to ketogenic, but certainly if anyone wanted to try the Atkins diet, I think it's certainly worth trying. You know, I think there's so many different things that we can do for tough epilepsy, and the important thing is never to give up, you know, always keep trying.
Okay, so parents often worry, understandably, about the long-term impact of both seizures and anti-seizure medications on the developing brain of a teen. Are there any long-term or permanent changes in the brain that can result from either seizures or anti-seizure medication? And if so, what are they, and what can be done to minimize the risk of those changes?
Again, those are very difficult questions. And I don't know that we have a good answer or a good, you know, good response. We know that seizures are not good for you, you know, especially with partial seizures, with temporal lobe seizures. So, you know, when we look at kids that have tough epilepsy, many times there's learning problems, there's learning issues, there's attention issues, and sometimes it's really hard to figure out what things are contributing to the differences. You know, is it what we call the neurological substrate? So you know, if a brain that generates seizures is also immature. So there's a brain disorder, and a seizure is perhaps just one expression of a brain immaturity or a brain disorder. So even when we look at, you know, apparently benign epilepsies, you know, for example, benign Rolandic epilepsy, which we used to say occurred in kids that were neurologically, developmentally normal. When we look at their MRI, it's almost always normal. But we do see a lot of electrical activity on the EEG in sleep. You know, what we find is that many of these children do struggle with learning, with reading, particularly with reading and spelling and arithmetic. So sometimes is it just part of the neurological disorder, the learning issues? Is it seizures? We know that frequent seizures, you know, especially if it's a more catastrophic type of epilepsy where you're having daily seizures or many seizures a day, we know that seizures can impact on learning and attention. or is it side effect of medication? So, medications work on the brain, and what they do is they suppress the brain. So, many medications do work, may make you harder for you to concentrate, harder for you to attend. So those are all the different things that we need to think about, the neurological substrate, the effects of the seizures, and the effects of medication. And sometimes it's hard to tease things out. Many children or adolescents, sometimes we've been on medications for many years, so we don't know what our children are like off medication. Sometimes it's only when we take the medication away. I've had children with, we've had them on trileptal for 2 or 3 years, and sometimes families forget what children were like before we started medication. And we take the medication away, and there's the difference. The child seems brighter and more alert, and maybe personalities change. So, medications do have effects. Now, whether they're long-term or whether there's any particular change to brain chemistry or brain structure, I think no one's actually proven that. So, but, in this day and age, we try and use medications which are less sedating, which may have less effect on learning. And then I think it's just to keep an open mind. Remember, every child's an individual, and one medication which might be good for one particular teenager or adolescent may not be the right one for someone else. In terms of long-lasting organ issues, we know that most of the medications are relatively safe. When we see the blood dyscrasias, the blood problems, the liver problems, usually they happen very early. It's a genuine allergy and idiosyncrasy. I think that blood testing for liver disorders, for bone marrow, is way overdone. No one has been able to prove that periodic testing of liver function, of blood counts, predicts those very, very few children who may develop a dangerous allergy. If you look, each medication is, I'm digressing here, I think, Russ, but each medication has about a 1 in 10,000 chance of a rare, potentially fatal, and potentially very serious side effect. I think it's more important that your neurologist spends time with you, explaining to you what the warning symptoms are, whether it's a rash with lamictal or with trileptal, rather than periodic blood tests.
Right.
They don't impact on growth. There's the debate about many children, and this is probably the most important one, especially living in Michigan, is bone health. And, seizure medications can impact on bone health. And I think that's probably the main issue.
And so you just recommend vitamin D and calcium supplementation?
Vitamin D supplementation, maybe monitoring, your vitamin D,
Okay. So teens often, and this is all teens, often exhibit mood swings or strong emotions, anxiety, impulsivity, and many other emotional and behavioral challenges. So how can changes in the brain related to epilepsy and its treatment exacerbate these challenges?
Yeah, again, these are good questions, and I'm not sure that we can give a good biological explanation about changes to, but adolescence it's a time of transition. It's a time of transition from childhood to adulthood, and it's a delicate time, and it's a tumultuous time, and I think there are many issues. It's a time that the adolescence is self-conscious. We don't want to be different. We don't want to be different from our peers. It's a time when our peers become more important than our parents. and at the same time, we're indestructible. We're still learning. Our frontal lobes are still developing. We're still learning to plan and see consequences. So I think it's a delicate time, and the issue of transition and can often contribute. So we do know that anxiety and depression and mood disorders are overrepresented in children with and adolescents with epilepsy. So I think there's many psychosocial factors which can contribute. Feeling different. I think what's important, how do we foster that spirit of taking control, of being responsible for your disorder? I think what we need to foster is positive relationships with the practitioner, positive relationships between the child and the parent. Because it's a difficult time for parents too. You feel responsible for your child. How do you let go? How do you not overprotect? I think it's hard for some families, and the letting go issue. So I think these are things that we all have to be to understand. So the adolescent oftentimes doesn't see ahead, doesn't have that abstract reasoning, that executive functioning, which, the ability to plan ahead, to see consequences. Sometimes we're indestructible, we act impulsively. So it's a growing time. So I think the important thing is for families to be there, to be supportive, not just judgmental. Your frontal lobe is developing. Now, maybe for kids that have frontal lobe epilepsies or temporal lobe epilepsies, that frontal lobe development takes a little bit longer. We do know that many children with epilepsy have an ADHD, and if you think about ADHD as a disorder of executive functioning, planning, persistence, organization, seeing consequences.
Right. So teens are also more likely to engage in risky behaviors. What behaviors should teens with epilepsy and their parents be most concerned about in terms of things like alcohol and drug use, distracted driving, sexual activity, you name it?
I think those are all things to worry about. I think most parents worry about that, and I don't think it's any different for a child with epilepsy. But if we think about teenagers with epilepsy, many times they feel different. They may feel isolated. And I think and even in adolescents who have seizures which are well controlled, they have to take medication every day so that they are different, I think the important thing is to foster positive relationships. Pediatric care, I sometimes say, is triangular. So if you can make a triangle with your hands, and we'll think about a triangle, and you have three people in the triangle. You have the parent, you have the physician, and you have the child, or the teenager. Sometimes it's quadrangular. You have two parents who hate each other. And I don't know if there's any situations like that. We do run that into the clinic sometimes too. So a parental conflict can sometimes make things tough and difficult. And what we hear from teenagers is that, and it's a trap that I try not to fall into, but I think most physicians do struggle. We all have productivity. I have to, every month, my chairman wants to know how many RVUs, which is a relative value unit, how many RVUs have I produced this month, how hard have I been working? And I think most physicians are under the constraints, but So one of the things that teenagers often say in surveys is that they sometimes feel left out of the decision-making process, in the knowledge-acquiring process. So sometimes, is that the doctor and the parent are sort of at the top of the triangle, and the teenager might be relegated. So I think we've got to think about that. We've got to, so we want to foster these positive relationships between the teenager and the physician. So what I try and do is I try and have sort of private time with the adolescent, with the teenager, so we can talk about issues that maybe they don't want to talk about in front of their parents. And I think it's also important for parents, again, to foster that, that non-judgmental I'll be there, because teenagers do make mistakes.
Right.
So, and it's part of growing up. You don't want to be too judgmental. But I think frank discussion about all these issues, driving is a very important one. Distracted driving. Alcohol is an issue that, is a concern. Sexual experimentation. So these are all things that, are important to have discussions about and, sort of have a plan. And I wouldn't want to put one more important than the other.
Yeah, sure. And it's true for all teens, not just those with epilepsy. So
Right.
So in addition to some of those behaviors like alcohol use, there's also stress and sleep deprivation and missed medication. These are all potential seizure triggers that teens with epilepsy may be exposed to. So avoiding these triggers is a key aspect of effective self-management. You also talked about being involved and being a key member of that triangle in your healthcare team and being involved in the decisions about your own health care. So how can parents help their teens to take on more and more responsibility for self-management as they transition toward adulthood? Given the fact that there may be concerns about memory problems, like they may be worried that they may not remember to take their medications, or they may be worried that they may not have the executive function to be able to see consequences of using alcohol, or see the consequences of staying up late, or that kind of thing. How do they help? Go ahead.
Yeah, I guess we don't have frameworks that we know work. If you look at the literature on self-management in adolescence, I sort of looked it up and there's really only a handful of articles about what is the best way of handling these issues, of encouraging self-management. And I think that's the advantage of, conference calls like this, is we can all get together and we can think about, we can share experiences, because there isn't one easy solution or one easy path. But I think there are some things which will help the adolescents on the path to self-management. One of them is knowledge. You want your adolescents to know about his condition. So education. And that's one thing that we can do at things like Camp Discovery, where the teenagers get a chance to talk about epilepsy with their physician and ask the questions. And a lot of them will ask about these issues like driving. They'll ask about relationships. They'll ask about pregnancy. About feeling different. So knowledge is, and so that can be done in many different ways. It can be, I think it's part of the physician's responsibility, because, if you look at teenagers with epilepsy, about a quarter to a third have had epilepsy since they were children. And they've probably forgotten the discussion that the parents had with the doctor when they were 6 or 7. So again, forums like the Epilepsy Foundation, like our Synapse program, Russ, which is we're going to kick off in October.
Mm-hmm. Right.
That'll be another good forum for adolescents. So knowledge is key. I think self-esteem is also important, and the teenager's sense of control. So again, how do you encourage independence? And self-esteem is something that I think you build in your day-to-day living. And then, I think you have to let go a little bit. There are going to be mistakes, but, think about practical things that you can do to try and make sure your teenager doesn't forget, So, taking your medications as part of daily routine. You take them at meal times. You set a watch, a small alarm clock. You use a pill box, use a chart or calendar. Maybe email, sometimes an email from mom or dad might not be as threatening or as, if you email, say, did you remember? It's not as like, did you take your stuff today? Or, you need to grow up,
Yeah. Okay. So in middle school and high school, participation in sports can be a great way to make friends and get exercise, but often parents may be reluctant to allow their teen with epilepsy to participate or in any kind of strenuous activities or activities where there might be like contact sports or that kind of thing. How can teens safely participate in sports, and which sports may require additional precautions?
Right. So again, this is, for people with epilepsy, you're battling enough, aren't you? You're battling having to take medications, feeling different, worrying that your friends, a lot of the kids at Camp Discovery will tell us this, they worry about their friends seeing a seizure and what are their friends going to think. So there's enough to make them feel different and socially isolated. So we know that recreation and ability to mix with other kids is very, very important. Now, it doesn't always have to be sports. Some kids are not sporty. Sure. So, but, what are the other avenues, whether it's art or for some, as a neurologist, I would never let any child of mine play football, whether or not he had epilepsy. I see too much concussion. I see too much, So and again, that's an individual decision. I didn't grow up in America, and I don't understand football, so I'm not. So I don't think not being able to. But again, that's an individual. So, and I've had families come in where, fathers wanted the child to play, the boy to play football. Mother hasn't wanted the child to play football. And it's been very difficult for me because I can't say that specifically because of the seizures you can't play football. Sure, there's a possibility that if you get hit in the head or you get a head versus head impact, well, sure, that might bring on a seizure, but, do you want to live in a bubble all your life? So, when we go to Camp Discovery, the teenagers do many, many activities. You have to be sensible. Keep your seizure precautions. You're going to be, water, you need special care, so you can swim, but someone's got to be watching you in case you have a seizure. The kids go rock wall climbing, and they go up very high, and I would never do it myself. But they're on a harness and a rope, so that if they do fall. So I know it's tough for families, letting go, but that's an important part of independence and growing up. So you got to let go.
Right. And driving is another rite of passage associated with adolescence. Do you counsel teens and their parents any differently about driving than you do adults with epilepsy?
I think, driving can be a carrot in the sense when we're trying to encourage teenagers to learn how to self-manage, how to maintain adherence, how to remember to take medications. Driving is often a carrot. I mean, the law in Michigan is you can take medications, you can, as long as you're seizure-free for 6 months, you can drive. And sometimes that's a little extra push that the teenagers need, because I'll say, well, I want to know that you are responsible enough to take your medications before I can support your driving. Now, it's got nothing to do with me, but it's and I think that's a little extra push that will sometimes help. I do tell teenagers that driving is a responsibility, and there are certain things they have to do. They have to remember to take their medications. They have to report any breakthrough seizures to the Department of State. Michigan is a bit different. Doctors do not have a reporting requirement. This is a whole other topic in itself. But I'm not a policeman, so my job is to tell you what the law is and what you should do. And I think if there's a reporting requirement, I think it undermines patient-doctor confidentiality. And then we talk about lifestyle, what I call lifestyle excess. You got to be sensible. Like the Greeks used to say, panen metrio, which means everything in moderation. Be sensible. Don't stay up all late all night because you're going to have a seizure. Don't go drink, don't do drugs. So that's part of that lifestyle moderation. That's an important key to managing and controlling your disorder. Right. Probably the other important thing that I think, especially when we think about driving in teenagers, is when I'm seeing a teenager and adolescent with seizures that hasn't had seizures for many years, it's always important to think about, could this be a time that we could try to get you off medication? And the reason is because if you get a driver's license and you stay on medications, so say you come to see me when you're 19 or 20, and you say, hey, doc, look, I'm on medication. I haven't had any seizures since I was 14. Do I really need to stay on medication? And you'll say, well, sure, we could try and get you off medication. But, if we do that, once we stop your medication, I want you to be off medication and seizure-free for 6 months before we let you drive again. And so for most young adults who are already driving, it's just, oh, well, look, doc, I'd rather keep driving. So if you continue on medication after your teen gets a driver's license, you might be making a lifelong commitment. So this is a good time to think about, do you really need to be on medication or not?
Right, that makes sense. Can you talk briefly about, you mentioned this a little bit earlier, but can you talk a little bit about some of the unique issues faced by teenage girls with epilepsy, things like birth control pills, the effects of valproic acid or Depakote, catatonic epilepsy?
Right. So these are issues, again, you want, I always have an early discussion with families. Pregnancy is not always planned, and, not sometimes, I don't want to say often, but every now and then we get surprises. So I think it's an important thing to have the sex discussion, the issue early on. If you want to try contraception, it's important to understand that some seizure medications may interfere with the oral contraceptive. And these are typically the older medications, what we call the enzyme inducers. So things like Tegretol, Trileptal, Dilantin, Phenobarb, they sort of make your body metabolize the pill much quicker. So if you're on an enzyme inducer, Topamax is a newer medication which can be a slight enzyme inducer. Then you sort of need a higher dose pill with sort of a relatively, a little bit extra estrogen. You don't want to be on a mini pill because, they might fail.
Right.
Lamictal has an interest. I don't know if you've got time, but if anyone has questions about Lamictal and the pill, we can talk about that. I always talk about the other issue is childbearing in women with epilepsy. Most women with epilepsy have healthy babies, but if you take seizure medication, there's a small increase in the risk of birth defect. So, any normal pregnancy, any normal baby is a miracle. But, even if you do everything right, you see your doctor, you take your multivites, you don't do alcohol or drugs while you're pregnant, 1%, 2% of babies will have a birth defect. Sometimes it's something small, a cleft lip, a funny-looking nail. Sometimes it's something bigger like a heart problem or a spinal cord problem. So even if you do everything right, sometimes 1%, 2% of the time we'll see a defect. If you take seizure medications, and there's a small risk, it increases a little bit, not a whole lot for most seizure medications. Maybe we'll say 4%, 5%. So just a little bit above that of the general population. The bottom line is 95% of women with epilepsy have healthy babies, though we do avoid Depakote. But I think it's a good habit for women, for young ladies, to get into the habit of taking folic acid every day, even when pregnancy is not planned, because we think, the birth defects happen in that first month before you're pregnant, and we want, folic acid can help prevent birth defects.
Right. And in terms of metabolic syndrome, polycystic ovaries, is that another reason you try to avoid Depakote? And
that's another reason we avoid Depakote as well, is because there can be weight gain, and it's again, it's a subject of some debate. Is it truly a Depakote side effect? Is it more manifestation of the epilepsy? Because both generalized and partial epilepsies have been associated with endocrine issues, like irregular periods and stuff like that. But certainly most people would say let's avoid Depakote.
Okay.
Though, Depakote is a good medication.
Oh, yeah.
And sometimes it's the most effective medication, All of us, have seen patients where we've tried other broad-spectrum medications, Lamictal, Keppra, Topamax, and then we have to do the Depakote because of what keeps you seizure-free.
Right. And just if you could speak very briefly about catamenial or hormone-related seizures.
Again, catamenial, it varies. 60-70% of women, estrogen brings on seizures. Progesterone can dampen seizures. So a lot of times we'll hear that seizures can be either more frequent mid-cycle or just before or around the time of the menses. Some doctors will try hormonal manipulation, but really there's no easy way of managing seizures where there's a prominent relationship to the period.
But it's probably a good thing for families to know, just to be aware.
And to let your doctor know if there's a pattern.
Any patterns, yeah, exactly. Okay, and one more question before we kind of open it up to discussion. At what point should parents start thinking about helping their teens to transition to an adult neurologist, and what are some recommendations to make that process go smoothly?
Right. I think it's something that you should start thinking about as early as possible. It's not something, and when I say as early as possible, 12, 13, and just talk about it in general terms, but usually by about 16 or 17, and I think it's a transition is always a difficult time, and I think there's many issues which go into how you transition or where you transition. I think the biggest difficulty may be for kids or adolescents that have cognitive impairments and behavior difficulties, because sometimes adult neurologists are not as equipped to treat those issues. So if you work if you're seen at an epilepsy center where there's both child and adult neurologists, often it's an easy transition. You're in the same building, and sometimes people will say, well, and again, this is a luxury because it's hard to do, because we all have to produce our relative, our value units. But sometimes, we'll introduce you, I'll bring my adult colleague in and say, this is James, and, and that would be the ideal way, where you could have, dual, have two doctors in at the same meeting, and you gradually transition from one to the other. Adolescents often like the transition because it's part of growing up,
Right. Okay. Did you have any closing thoughts on successfully managing epilepsy in adolescents before we open it up to discussion?
Well, I wish I had an easy answer, and I don't.
Right.
But I know that it's a difficult time, and there's no easy solution, and I think the challenges are managing that transition, emphasizing and helping your teenager learn to self-manage, I wish we had a cookie-cutter solution, but every child is different, every family is different, and I think you want to use as many supports as you can. You want to use your professional, you want to use your Epilepsy Foundation. Actually, if you Google Epilepsy Foundation or just Google adolescent self-management, there's a lot of supports, isn't there, in the epilepsy. There's a toolkit, isn't there, Russ?
Yeah.
That the Epilepsy Foundation produces.
Right.
So, yes, I think it's discussion and networking. I think part of it is networking, and it takes a village to raise a child, as they say,
right,
or to manage the transition.
Right. Great. So I'm going to open it up. I'm going to unmute all the lines now, and before I do, just if you do have background noise and you're not asking a question or making a comment, if you could still mute your own phone, either using the mute feature on your phone or by dialing *6, that will mute your line so we don't have any background noise. And then if you have a question or a comment, you can just dial *6 again, and that unmutes the line. So, so let me just unmute everyone right now.
All guests have been unmuted. You will now rejoin the meeting.
Okay. So before we open it up to questions, would any parents on the call be willing to share some tips on how they've helped their teens to take on additional responsibility for self-management? Or any tips on anything that you've done that has helped your teen through the transition, through the tumultuous times of adolescence? Okay, got a quiet crowd today. Maybe we can come back to that.
Hi, Russ. This is Sarah Bailey.
Yeah.
I have a almost 16-year-old daughter, and we're blessed in that with medication she looks and acts like every other teen, which is to say that the emotional turmoil and the transitions about friends and wanting to appear normal, quote unquote, that's all part of raising a teen girl, I think. And the epilepsy adds, I think, a layer of complexity or maybe it's not any more complicated. It just feels like the conversation sometimes, you want to stay away from emphasizing that she's different in any way. And I guess I have a shout-out, and then I have a question. So my daughter attended Camp Discovery for the first time this summer, and I kind of thought it was, for her, overkill, because I don't think of epilepsy really as sort of a daily thing. She's certainly on daily medication, but she's blessed, again, to be relatively seizure-free. It was so good for her, though, to be among kids where that's truly the norm, and to figure out that, yeah, these are normal-looking kids, and they're probably your classmates, your friends, whatever. So that was a hugely positive experience for her.
Great.
She is growing more independent, though. Here comes the question. She's never worn an ID bracelet. We sort of figured that, hey, we'd be nearby or around if anything happened. What are your thoughts on sort of self-identifying and the risk of being called out in a peer group versus it would be helpful for a responder to know that this is, I guess, not an unexpected seizure or some sort of seizure emergency?
Sure. That's a good question. Dr. Constantinou, do you have any thoughts on that? I can share my thoughts as well. But
yeah, sure. Well, I think that just to address firstly the comment about Camp Discovery, I mean, I think that's the advantage of it, because I think a lot of times kids with epilepsy, I mean, epilepsy is common, 1%, 2% of people have epilepsy, but I think even in this day and age, it's something that people don't like to talk about. So a lot of times the kids do feel isolated, and I think one of the real eye-openers for the kids, and this comes back to knowledge, right, and how knowledge and control can contribute to self-management, and they just see so many different kids, and they see kids with mild epilepsy, kids that are well controlled, and so I think it's a really valuable thing, and it's one of the things that I love going to. In terms of the ID bracelet, I have mixed feelings about it, and I'd be interested to see what Russ says, because I think it's a label, and I think it sort of pigeonholes you, and people do funny things with labels, at school, and you can be, I've had children that aren't allowed to climb stairs by themselves because they have epilepsy, so I think that you have to have a really good reason to want to wear a bracelet. I mean, let the school know. There's always the possibility that you'll have a seizure in that. But first responders respond to seizures. So I'm not a big fan of them, I must admit. But there's pluses and minuses. I don't know. What do you think, Russ?
Yeah, I agree. It's a very, very individualized decision, and if she is not on board and doesn't feel like it would be necessary, and if her seizures are not that frequent, then it's probably something you can skip. And if you do think it's important, however, there are ways to do it that's maybe a little less stigmatizing, and that there are some of those gel type bracelets that all kinds of, like, kids wear them all the time. I don't know, they still do. I know my kids aren't quite old enough to be wearing those yet, but there are some online that are very discreet and don't have that typical medical or bracelet look about them, so that's one option. For kids who have more frequent seizures, there are other options. There's seizure detection and alert devices. There's the smartwatch and the Embrace watch, which are newer devices that actually alert you. They can alert a caregiver if a tonic-clonic seizure is detected. It's movement-based, and it's paired with a smartphone. So, and it can even let you know, use the GPS in the phone to let you know where the person is. So I think when you're having frequent seizures and you want to be independent and out in the public and not worried that you're going to end up getting automatically taken to the ER because a person trying to do the right thing, calls 911. It's a reasonable thing to consider, but again, based on how often you have seizures, if they're infrequent, it's probably a little overkill, like Dr. Constantinou suggested. Anyone else have thoughts on that?
My name's Nicole, and my daughter is 10. She's almost 11. She's had epilepsy since she was 7. She helped me pick out a medical alert bracelet through a website, Lauren's Hope, that they are very much geared towards youth. It's a paracord bracelet, and so the kids are wearing those type of things, and they have different styles that the kids are wearing.
Right.
She has a fancier one that's metal with a horse design on it, but it has the medical alert notification on there. My biggest concern has always been she's with me and I'm available, but if we were ever in an accident, I needed some kind of assurance that someone would know she has this condition and who to get in touch with to find out what she needed. Right. So it wasn't just about, if she had a seizure, because her teachers know and the school is very good at working with us, but if anything were to ever happen to us, heaven forbid, that they would know that she had some special needs, that she needed attention.
Okay.
Yeah, so I think it's different for everybody, and there's always different considerations.
Yeah, I agree.
Okay.
I appreciate that, and we did look at the Lauren's Hope bracelets. I had forgotten about those. They are really, really very nice and discreet. They look like any other piece of jewelry.
Yeah, exactly.
That's a great resource. So. Thanks. Okay, well, let's go ahead and open it up to questions. Does anyone else have any questions for Dr. Constantinou or for anyone else on the call, for other parents?
Hi, Russ. This is Dawn.
Hello.
Can you hear me okay?
Yep.
Hi.
Yep.
I have a question. Let me just give you a brief background about my son. He is 7, and he had his first seizure at 3. He had 5 complex partial seizures that year, but he's doing fine on medication. He's taking trileptal and Keppra, and he's been seizure-free for almost 3 years now, which is wonderful. And he's reading, he's speaking 2 languages. There's no trouble at all. So, as you mentioned, it's smooth sailing epilepsy for us so far. But still, I have concerns. I wonder about what's going to happen. Third 24-hour EEG to determine whether or not we can begin to take him off the medications. So my question is, what happens when children start to come off their medicine? What's the procedure? What do we expect? And how many? Go ahead.
So how old is he now?
Mark will be 7 next week.
All right. And so he's 7 years old. And how many seizures did he have?
5.
5. And how long was what period of time did he have the 5 seizures over?
1 year. He had his first one January, his second one February, his third one in the middle of the summer, and 2 in the month of November. And that's when we added Keppra.
Right, and that's what made him seizure-free, huh?
I think so.
Do you know what his EEGs have shown?
Yes, the last 2 that he's had, they show that the spikes and waves make him still more susceptible to seizures. And that's really all the information they gave me after they looked at the EEG. You're
not sure where they're at, or
no,
whether they. I mean, it's always a tough decision. When do you stop medication? And it's something that families and I struggle with every day. Because at some stage you have to bite the bullet, and. Do you do it at 3 years? Do you do it at, how many years has it been for you?
Well, in this coming November, it will be 3 years seizure-free.
Right. So is it 3 years? Is it 4 years? Is it 5 years? So, and I've become more conservative the older I've got. I often prefer to wait longer. because it's nice not having seizures, right?
Right.
And if the medications are well tolerated, certainly, depending on the EEG findings, if the EEG was still active, I'd probably wait a little bit longer, If we look at, what are the predictors for remission, one is number of seizures that you had before you got seizure control. And, kids that have many seizures may be less likely to outgrow epilepsy. So, with 5 seizures, over about a year, I might want to go a little bit longer, at least 3 years, maybe even 4 years. If his EEG is active, I probably would go longer as well. And the thing is, there's no firm guidelines. A lot of times it's it's like a good cook. This is what I think I should do. And, we talked about Dr. Camfield in Canada who, how he was able to predict who was going to outgrow the epilepsy only about 50% of the time.
Right.
So, I think the right time is the time that feels right for you. If you said, look, he's doing well on medications, he's doing well on school, I'd like to wait a little bit longer, I think that's fine.
Okay.
You don't have to stop medication. And you can say, look, I'd rather, you can say, I want to see, do you know what I'm saying? When I stop medication, I usually do it very gradually, and again, it's hard to say, but what sort of doses is he on? But I prefer to cut back gradually, over 3, 4, do things slowly. People always want, if a seizure is going to come back, when is it going to come back? And so usually what I'll say is if you go 6 months without a seizure after stopping the medication, you're 75% out the woods. If you go a full year, you're 90% out the woods. So usually you'll know within 6 to 12 months when the seizures are going to come back,
Right, if they are going to come back after the medication.
If they are going to come back, that's right.
When you had mentioned about a child coming off of Trileptal, that the child was brighter and more alert. My son has been taking medicine since he was 3. He's a different child now. I don't know how different can he be if the medications are removed.
Yeah, and that's what I hear all the time is people say, I don't know my child off medications. He was only 2 or 3 when we started the medication. And, it's not common, okay? It's not like it happens every time. Mm-hmm. But, yeah, certainly it's hard to say how whether they affect his mood or his personality. Sometimes you don't know till you stop the medication. But most kids, it's not the big difference,
Right. Great. Thank you so much.
Thanks.
Other questions?
This is Nicole again. I have a question. One of the things I've heard various times, and you just briefly mentioned it, my daughter's seizures are not under control, and she's currently taking 3 medications. And where you talk about, the likelihood of the amount of seizures and the duration of time that's transpired that they are less likely to outgrow them. Do we attribute that to what I'll term muscle memory in the brain, that your brain starts to learn this behavior and so it's hard to unlearn that behavior? Is that research?
Yes, so this is, it's a very controversial topic.
Okay.
But there's a phenomenon called kindling. And what kindling means is that seizures beget seizures. So every time you have a seizure, it lubricates the pathway. So it becomes, once you had a seizure, it's easier to have your second one, and it's easier to have your third one. Now, kindling has been proven in rats, it's been proven in cats, it's been proven in just about every animal. But, so what they do is they'll get a little rat, and they'll stimulate its hippocampus, and they'll buzz the hippocampus, and then, you can bring on seizures, and eventually the seizures will happen by themselves. Now, if you get 100 epileptologists in a room and you start talking about kindling in humans, 50% of them will be on the one side. They'll say it happens, and the other 50% will say it doesn't happen. And within a few minutes, they'll start throwing rotten tomatoes at each other. So it's very controversial. Some people believe in it. Some people don't believe in it. I'm on the fence a little bit. I think that some epilepsy is real tough epilepsy, and it's tough from the get-go. Sometimes, but a lot of times I'll see people in the adult unit who tell me that their seizures have become more frequent with time. So even though there's no proof, a part of me believes that it may be an issue. And that's what we were talking about earlier, Russ, about why do we want to do early surgery? Because, you know, the earlier you do surgery, you haven't not been working, not been driving for 15, 20 years. But maybe that, so you can prevent memory problems. And again, like there's no proof when we're talking about the plasticity. But has your child had monitoring?
Yes.
Okay. And do they think surgery is an option, or?
It's questionable at this time. They said they found a generalized area that it's coming from, or a general area that it's coming from, but cannot pinpoint. We've done the PET scan and done the extended EEGs, but can't pinpoint.
Right. Okay.
At this point. The other question I had was, so the type of seizures that she's had. She started off. She had 2 grand mal within a week when she was 3. Then nothing else until she was 7, and they came on like gangbusters. Every 3 to 7 days she was having them. We put her on Keppra. She was stable for 8 months, and then again they came on like gangbusters and saw the same type of pattern. And we put her on Lamictal, and that reduced the grand mal, but brought on a variety of other types of seizures where more absence or some other variations, and then since that got a little bit out of control at that level, they added another medication, and unfortunately the third medication they added that created a significant medical reaction to. So she ended up on this other medication, third medication. But at each medication we've seen the seizure type change. So I don't know if now she's evolving and she's one of those candidates or one of those individuals who just has epilepsy that, and I forget, is it Lennox-Gastaut, that shows itself in various ways, or is it the medication modifying it to come out in that way? Is there any?
Yeah, it's always a hard question, but certainly we talked about a silent period in epilepsy, and sounds like from 3 to 7. So, certainly also. In difficult epilepsy, it's not uncommon for us to see what we call a honeymoon effect. So, we'll try medication and then it works like a charm for a while, and then the seizures come back. And I think it's just, unfortunately, it's part of difficult epilepsy. So you start a medication, you do wonderfully for a month or 2, or sometimes even a few months, and then boom, all hell breaks loose. Now... so we sound like we're dealing with a bit of a honeymoon there. Now, certainly, but sometimes, it depends, certain medications are better for certain seizure types. So, some medications can make certain seizure types worse, but it's hard to say without knowing exactly what type of seizure it is, or, whether there's another medication which might be better for her,
Yeah, the hardest part is the trial and error, and then having had a serious side reaction to a medication last year that...
what medication was that?
Sonogran, and she ended up with systemic lupus.
Oh, my goodness.
It was horrible. And so, anyway, it's, the idea now, they want to put her on Depakote, and I'm just...
yeah, and I mean, it's always a tough decision, but, Depakote, and it sounds like we're dealing with a mixed seizure syndrome. different types of seizures, and Depakote is a broad-spectrum medication which covers many different seizure types. And I don't want to say this is Lennox-Gastaut. I think it's something that you need to ask your neurologist.
Yeah, because she doesn't have any other cognitive issues. I mean, she's very... So.
Right. But you don't always get the cognitive issues, but
okay.
Depakote's a very effective medication in kids with multiple seizure types.
Okay.
But I hear that you're worried because of that reaction to the sonogram.
Yeah.
Okay. We have time for maybe one more question.
Hi, Dr. C. Hi, Dr. Constantinou.
Hi. Sounds like someone I know.
Yeah, this is Zahra.
Hi.
Hi. In regards to medical cannabis, how long do you wait before with kids before regarding that as an option?
Yeah, again, that is it's different for everyone. I have reservations in thinking about medical cannabis for kids that are relatively cognitively intact. For someone that's going to school and doing fairly well at school, maybe only borderline mild. It's hard for me because it's hard for me to sort out potential seizure benefits, and we certainly can't say that medical cannabis works. We have good anecdotal reports, but we can't be definite. So for someone that, so most of the kids, and that I fill out the state form for, are kids that have catastrophic epilepsy. So we have significant cognitive impairments. We have multiple daily seizures, and we really have nothing to lose. I do not think that cannabis should be used on its own, in the sense that some families will come to me and they'll say, "Doc, I just want to try the cannabis." And no, I can't support that because we don't know that it works. And I've had experience with some people where they've just used the cannabis, and we've had sudden death. So I think cannabis is worth trying. Everyone's different. But I think it has to be in tandem with conventional seizure medication. I would like to try at least a couple of medications, 2 or 3, before I say it's time to go to medical cannabis. But again, if it's a catastrophic epilepsy with multiple seizure types, you can work through the medications pretty quickly.
Okay.
So again, for everybody, it's an individual decision, Does that make any sense?
Yeah, thank you.
Great. All right, well, it is time to wrap up the call, so I want to thank everyone for participating, and thank you so much, Dr. Constantinou, for filling in at the last minute and obviously doing a great job of dealing with the complexities of epilepsy in adolescence. So thanks everyone for joining us, and hopefully some of you can join us next month. The next one is cognitive function in epilepsy, and we have a neuropsychologist. Thanks again.
Thank you,
and
thank
enjoy
Russ
the rest
for
of your summer.
Okay, take care.
Thank you.
Thank you, Russ. Thank you, everybody.
Thanks.
Bye.
All right, bye-bye.